Morning. Good afternoon to all of you in this time that you are receiving my lecture. My name is Dr. Patrick Muglaya, and welcome to the second semester. Most of the lectures we have here will concentrate on surgical anatomy of the different organ systems. And for this afternoon, we shall be discussing the surgical anatomy of the lungs and diaphragm. I'm a thoracic cardiovascular surgeon by practice, and I've been handling a group of well-respected and diverse faculty here in the AUF Surgery School of Medicine. And we would like you not to be trained as surgeons, but to get the basic concepts of surgical anatomy and correlate it with all your other medical subjects. So allow me to share my screen. So a short lecture on the surgical anatomy of lungs and diaphragm. We are do that again. Okay, so the gross anatomy of the lungs, as you have probably encountered in your readings, would show us that there are five lobes of the lungs. There is obviously the bilateral aspects. We have the right hemithorax, and the left hemithorax, and particularly different or unique with these is that the left lung has what we call the lingula here. Lingula because it is said to be similar to a tongue. The terminology lingula is suggestive of the tongue, and this is actually the anatomic partner of the middle lobe. So you have to remember that the two aspects why this has two lobes is that because there's a cardiac notch, obviously for your heart, and the lingula, which is the anatomic counterpart of your middle lobe. So safe to say, the right lung has three lobes: superior lobe, middle lobe, and inferior lobe, and the left lung has a superior lobe and inferior lobe. The fissure which differentiates or divides them is here is the oblique fissure, and obviously here because you have three lobes, you have two fissures. You have the horizontal fissure and you have the oblique fissure. So lateral landmarks here would say that the horizontal fissure is in parallel with the nipple line. So you would remember anatomically, your nipple line would coincide with your horizontal fissure. So gross anatomy here is a cadaveric dissection. You'd see that the lungs are placed in a coronal section. You'd see that from the front, the anterior chest wall has been removed for medical purposes, and you see here that the right lung and the left lung is situated on either side of our middle mediastinum, which contains the heart. So you see the central structure. This is obviously the heart, which is covered by visceral and fibrinous layer of pericardium. You would see here is technically the thymus. The neck would be here. You have your right and your left extremity, and you have the diaphragm here and your liver, which occupies a big portion of the abdomen. So you see here the right lung, supposedly with a horizontal fissure, as you see the division, and probably the oblique fissure is somewhere here. So if this is the horizontal fissure, this will be your superior lobe and your middle lobe. There's actually a remnant of the oblique fissure here, but I don't think it's evident or delineated for your learning. So here, as I said, the left lobe has the left lung has two lobes, the superior lobe, and you have here most likely is your oblique fissure here. I think this is one that's been pointed to, and this is your superior lobe, your inferior lobe. So it's safe to say that this is your mediastinum, and the right lung, the left lung, the pericardium would be here, right? So borders would be the thoracic inlet, the suprasternal notch would be here, the diaphragm, then the lateral borders would be this would be your ribs, and this would be your axilla. Hope everything's clear. So here is a eggshell cut. No? Eggshell cut meaning you're seeing the organ, or you're seeing the torso from below, and it is cut at the probably the level of the bifurcation of the pulmonary artery as seen here. So this is the left pulmonary artery and the right pulmonary artery. So probably this is a cut section, as I've said, no, maybe I said it wrong, but stand corrected. You are seeing this from the top. I hope you understand that. So a body is actually lying down on the like your cadaveric exam or your cadaveric dissections, if I may, um, and it is being cut axially. So the foot is somewhere at the bottom or at the distal part, distal edge of the table. So this is supposed to be the aorta, which should have had a curvature upward. So it's been cut section, and you see here that's on its right is the superior vena cava. So obviously this is the right atrium, and aorta arises from the left ventricle, right? So the pulmonary artery should arise from the right ventricle over here. So it pulmonary artery bifurcates into the left pulmonary artery and the right pulmonary artery, which brings deoxygenated blood, no? From the right pulmonary artery, from the right ventricle, right? Right ventricle gives you deoxygenated blood, goes to your gas exchange. We'll go to that later as your respiratory unit, which is the alveoli, then goes back by your pulmonary veins, which carry oxygenated blood now going into your left atrium, left ventricle, goes to your aorta. Other structures involved would be the esophagus here, or the digestive tract. So you have your aerodigestive tract here. The trachea should be somewhere here because this is the left bronchus and the right main stem bronchus. So we call them main stem because they're arising from the trachea itself. So here, as I said, the curvature of the aorta somehow curves here and should have landed to the thoracic aorta, and that descends down to go to the abdominal aorta, to the iliac vessels respectively. Here, another view of the lungs, which we see from the medial aspect, which because as a favorite exam question or anatomical consideration is that we are seeing the hilum. This is what we call the hilum. So when we say the hilum is where the organs are connected to a certain body, right? For example, if you have the kidney hilum, you'll be having the renal artery, renal vein, and the ureter. So here on your hilum, you should be able to appreciate a pulmonary artery, pulmonary vein. Remember, vein, but why is it colored red, right? Vein because it carries oxygenated blood, right? Arteries, blue, deoxygenated blood. This is the only segment in the body wherein you have arteries carrying the oxygenated blood, and you have the bronchus. So if you want to compare, or if you want to identify, obviously, if you would like to have clues on which is this the left lung or the right lung, the answers might be pretty obvious because of the orientation. Like you would see that the apex is already on the top, and it somehow the fissures are here, and somehow the notch is here. So just to objectively put it, you would see a horizontal and oblique fissure. So that one will this probably be the right lung. The left lung would only have an oblique fissure. Again, the orientation of the bronchus. The pulmonary artery is on the left lung is superior in nature, superior. In the pulmonary artery, it's anterior in relation to the primary bronchus. So if you have the primary bronchus as a landmark or as a reference point, pulmonary artery is superior to the bronchus on the left lung. On the right lung, the pulmonary artery is on the anterior portion or anterior segment with respect to the bronchus. Pulmonary veins inferior. On the left lung, the pulmonary veins are anterior and inferior to the primary bronchus. So this plays a very good role whenever identifying when you do your lobectomy. Lobectomy is removal of the lung for lung cancer, hemoptysis, or any other both absolute and relative indications. So if you're able to appreciate this, you should be able to understand the gross anatomy of the lungs from the anterior aspect, from the hilum, and from the cross section or the coronal aspect or the axial aspect. So again, with respect to the bronchus, you should be able to understand here a clue. There is a horizontal fissure, there's an oblique fissure. So probably both two fissures. Probably this is the right. Gave it away. The fissures gave it away. And again, with respect to the primary bronchus, the relationships of the arteries and veins. Here another, but this is different. When I say axial cut, the previous illustration we showed you is that somewhere here was the previous picture. The axial cut was done here, superiorly. Now we have a mid-thoracic axial cut, and you should be able to appreciate in the middle a cut section of the heart and other organs such as the esophagus and the aorta. You would not see the bronchus or the trachea here because it's probably more distal or more caudal in nature. So here you see the cut section of the heart. You would see the chambers. These are the ventricles, and this is the atrium. Atrium because you know that the connections, they are capacitance vessels, and here you see the pectinate muscles. So most likely these are the atrium, and the muscles are thin because, as we all know, the ventricles left and right, they have more muscle mass. And what would help also are the number of valves, but the valves are not seen. So by just muscle mass and orientation, this appears to be ventricles and these appear to be atria. It's the right atrium and the left atrium. So you see air bronchogram on your chest x-ray. Probably you got this from our radiology. Air bronchogram is the bronchi. This is the more distal part of the airway conduction system. We have the trachea and we have the right and left main stem bronchus going to your bronchioles and then going to your alveoli. So they are called bronchi. You see like that. And further posteriorly, vertebra and your spinal cord. Right? Everybody understands this? So the airway conduction system or the bronchial tree are a system of tubes formed from the primary bronchi and their bronchus. So we see, as I mentioned a while ago, we have the trachea arising from your aerodigestive tract, from your mouth, oral cavity, larynx, hypopharynx, and then larynx goes to your trachea. And the obviously this is not part of our discussion because this is more proximal, but just to illustrate to you, primary main stem would be the right and left, and then entering into our lungs and lungs would be the secondary, tertiary, and the BPS is called the bronchopulmonary segment. The bronchopulmonary segment houses the alveoli as a unit of respiration. And in relation, cartilage in the walls decrease as you go distally because the smooth muscle will increase. It will increase with these branching. So to illustrate to you, trachea. Here you probably have the left main stem bronchus or the left primary bronchus. Now it divides into the secondary bronchi. You see here that the intense cartilaginous plates from the tracheal rings suddenly become minute and become dispersed. The cartilaginous rings decrease as smooth muscles increase as far as extending into the bronchopulmonary segment and the alveoli as a pulmonary unit. So in physiology, we all know that deoxygenated blood goes through our network of blood vessels, and when they actually go into the bronchopulmonary segment and the alveoli, what happens is oxygen is harvested by our alveoli, the conducting system. Here is probably an electron microscope showing you how intricate or how it's actually formed, as reminded to me by a similar beehive, which is very uniform and architectural in nature, wherein the oxygen is trapped here, and then the blood vessels would harvest with its hemoglobin or heme as its oxygen carrying capacitor, and then obviously the famous oxygen and carbon dioxide gas exchange occurs. And again, pulmonary veins growing into your bronchial veins exchange and go back via the deoxygenated blood and then goes back via your veins. The veins carry oxygenated blood, goes back into the pulmonary circulation. So this is the anatomical explanation of how gas exchange occurs, because it is actually here shown that the alveoli has a direct communication with our neurovascular bronchial bundles. And just to mention, lymphatic vessels are here as part of the immune process or disease process. You produce mucus, you send in the T4 cells to combat your pneumonia. So this is how actually gas exchange takes place. So the respiratory membrane is simple squamous epithelium, and the endothelial lining lines the adjacent capillaries where their blood exchange is made possible via a fused basal lamina. The cells of the respiratory membrane are characterized as septal cells, which are responsible for the surfactant, which physiologically in newborn would prevent alveolar collapse. No? We are familiar with this surfactant after 32 weeks of gestation, that surfactant is being produced maturely, and this is by the septal cells. So the alveolar macrophages are, as I said, part of the lymphatic network, which is responsible for the immune system. When you see words such as macrophage, engulfing, foreign, patrol, so these are defense mechanisms of the body. Blood supply to the lungs. For the conducting portions, being the bronchopulmonary segments, that would be from the external carotids, thyrocervical, and the bronchial arteries. From the respiratory exchange circuit, that would be the arteries of the pulmonary circuit. Actually, it probably implies these are the bronchial arteries. So the pulmonary veins, as I said, veins, but they actually bring oxygenated blood. Vein, but they bring oxygenated blood back to the left atrium. Pleural cavities and its pleural membranes are coverings, which is divided into both parietal and visceral, as also discussed in our abdomen. Visceral would mean adheres to the organ itself. You have visceral peritoneum. So here you have visceral pleura, pleura that adheres to the surface of the lungs, the organ itself. So the parietal, on the other hand, attaches to the pleural cavity. It's responsible for housing pleural fluid in between. So in between the parietal and the visceral pleura, there should be enough pleural fluid to lubricate whenever you do your respiration. Whenever you do your inspiration and expiration, you have to have the lungs sliding through the intercostal spaces. So you should have at least physiologic pleural fluid. So here in inspiration, we just talk about volume pressure relationship. So when you increase the volume of the air inside, it is coinciding that the pressure decreases. So we all know that respiration is an activity where there is actually muscles of inspiration and expiration, but this is actually triggered or mediated by the gradient of intrathoracic pressure. So as I said, or as we said, pressure goes from high to low, right? So if there's decreased pressure or decreased intrathoracic pressure, air would actually go into the lungs or into the organs. So what happens is, consequently, you decrease intrathoracic pressure through your inspiration, the volume increases. So that's how air enters, not solely by I just inspire and make my muscles contract. So you should be able to recognize that aside from the contraction of the muscles, there is increasing negativity That's what we say. No? It's a parallax, but increasing negativity means there is decreasing intrathoracic pressure. No? Increase negativity. No? It's a parallax. You increase the negativity. So what this means is that you decrease the intrathoracic pressure so that air flows um, from a pressure of high, which is the atmosphere, to your lung. Expiration would actually dictate you the other way around. So when you rise your intrapulmonary pressure, the air flows out of the lungs into the atmospheric pressure to at least equate. So that's how inspiration and expiration occurs physiologically. So prior to our discussion on pleural effusion, I would just like to share with you that pleural effusion occurs in different spaces and in different spaces of our pleural cavity, maybe on the right or on the left. I'd like to share with you a video on one of the physiology or pathophysiology of pleural effusion. So you see here that there is a needle performing infiltration of local anesthesia. You're seeing pleural effusion, which is the serous fluid. So by anatomy, you see that the patient is positioned on a sitting position, and the needle accesses or places itself in the thoracic cavity. So there is pleural effusion now. So you see pleural effusion is decreased and the lungs are able to expand. So that is how actually pleural effusion is therapeutically aspirated. So it's an abnormal, as I said, pathologic accumulation. There is a normal amount, probably 50 cc, but if you see what we call 1, 2, 3 rib spaces, intercostal spaces covered, if we have somehow generated a eyeballing effect that per intercostal space it's 100 cc. So if you have 3 intercostal spaces which are filled with water, pathologically because it's beyond the normal, probably this is 300. 1, 2, 3 intercostal spaces, so that's probably 300. So effusion is an abnormal accumulation of fluid in the pleural space. There are 5 major types of pleural effusion, and the two being just basic is the transudate and the exudate. You have to remember that when you say exudate, that would be part of the empyema, hemothorax with trauma, and the chylothorax with other examples of malignancy. So concentrate yourself on these two terms, transudate and exudate. Exudate would be infectious, would be traumatic or blood, and chylous would be from the forms of cancer. Transudate, on the other hand, would be in relation to organ dysfunction. Transudate would be in the form of serous fluid and not like your empyema. Empyema would present as empyema. You have their thick viscous fluid. Probably I'll show you in the other slide. Transudate would be serous fluid. It's just almost clear fluid with a tinge of yellow. And this is seen with your organ dysfunctions. As I said, you have pericarditis, you have a pleuritis, you have a nephritis, you have cirrhosis. So those are 4 organs, as I said, respectively, heart, lungs, kidney, and your liver. So when you have problems with your organs, what happens is that excess fluid buildup goes into the specific pleural space. So you have pathophysiology of pleural effusion, as I said. We concentrate on the 3 here, which probably are the empyema, probably are the chylothorax, and these are the exudative. No? Exudative. This is exudative also, pneumonia. So as I see here, CHF is heart, atelectasis is lung, hypoalbuminemia probably in kidney. So these are the transudative, transudative types of pleural effusion. Workup of pleural effusion is usually by a chest X-ray, but we have included chest ultrasound. Ultrasound is use of sound waves in reflecting fluid, because we all know gradients in volumes of water are being identified by ultrasound waves as how they penetrate and go back to a certain measurement, or what we call the transducer. So X-ray would be able to show you opacity. But somehow we have seen that this opacity could be a solid mass or water. So what is sensitive is a chest ultrasound. So here we're just showing you that there is opacity of the left hemithorax, I'm sorry. And here we see that the patient is in lateral decubitus. So lateral decubitus means you ask the patient to lie down on one side, on one probably right decubitus or left lateral decubitus. And if the fluid actually levels meaning it follows the shape of the thorax, it means it's fluid, it's mobile. So approach to pleural effusion, what happens is that the patient comes in probably with symptoms, cough, dyspnea, unable to sleep, or sometimes back pain. So when this happens, you perform an X-ray, and as I said, here you can perform an ultrasound or probably a CT scan, an incidental finding, or you probably would be performing a CT scan of the abdomen, and the pleural effusion would be what we call incidental finding, or in Tagalog, mahagip, makikita. So as we see, these fluid is aspirated, as we saw in the video, and this is being submitted for pleural fluid protein, LDH. And you have your Lights criteria to be able to determine if this is transudate or exudate. So what we do is we get the value for the pleural protein, pleural LDH, and we also get simultaneous serum. Serum is blood, so we get the serum protein, we get the serum LDH, and what we do is to make a ratio. So if we got the pleural protein, the pleural LDH, and compared to the serum, we should have comparisons, and it would form a ratio. So it's more than 0.5, more than 0.6, or more than 2/3 the upper limit of the normal serum LDH. That would be an exudate. Another way of helping this is to identify, is again, as I've said earlier, the etiology. So if you saw exudate, that would be in the form of malignancy, infection, chylothorax, malignancy also. In transudate, you have the end organ damage. You have CHF, congestive heart failure, that's the heart, cirrhosis, liver, nephritis, kidney, and you also have your pericarditis, you have your pleuritis. Lupus, erythematosus, or SLEs, they have pericarditis and pleuritis, serositis. So these are forms of transudate. So again, for transudate, you just treat the organ damage. You treat heart failure, treat cirrhosis, and necrosis. In exudate, you should be able to identify the etiology. Obviously, if it's lymphocytic, or if it is tuberculous, you should give anti-tuberculous medications. If it is actually enough to perform a chest CT scan, because you have no diagnosis whatsoever, then you should perform a CT scan or another form of imaging, because we should be able to see mass, or again, pulmonary embolism. So as I said, this is how fluids are seen. So here, white, this is milk, this is chylothorax. Here, this is a yellowish, thick, this is probably empyema, and probably with a putrid odor as well. So Lights criteria, if it's a transudate, it's from CHF. I keep repeating myself. Organ failure, cirrhosis, nephrotic syndrome from the kidney. Exudate would mean pneumonia, infection, malignancy, and pulmonary embolism. Tuberculosis is also part of the infectious spectrum as far as exudate or pneumonia is concerned. They're bacterial, tuberculosis. So we move from thoracentesis to chest tube. Chest tube is performed when you have empyema or drainage. When you have empyema, it means you have infection in your pleural fluid. So what we do is to insert a chest tube to drain empyema, complicated effusion. Hemothorax is blood. This is from your blunt and penetrating traumatic injuries, and malignant effusion. So let me share with you. You would appreciate. I'll try here. So here is a video of chest tube placement, which you should appreciate. I hope the audio is acceptable for you. So as he's narrating, you should be able to delineate the anatomic landmarks. This is performed in IV sedation, so the patient is actually on anesthesia already. So the cross section shows you that the dissection goes into the pleural space, and it's on top or superior superior to the rib. So cephalad means superior to the rib because their neurovascular bundle structures are at the inferior of the rib. If you place your blunt instrument inferior to the rib, you might encounter bleeding from the intercostal arteries, intercostal vein, or pain from the intercostal nerve. So here what he does is was able to do a path for the chest tube. So this is a fairly good demonstration of how a chest tube is placed. So he was able to identify landmarks, and the confirmatory sign here is sometimes air comes out or blood comes out. No? So when it comes out, you probably would say to yourself, "Oh, I'm in the chest cavity na already." So when you put in the chest tube, you have to be secure it with the sutures. Yep. So you see here, it's a collection device. In the Philippines, we have seen this, but most of the times we use a bottle where there is water seal. So you see here that he is telling you that there is a 2 centimeter water pressure. So 2 centimeter just means measurement of the water because 1 centimeter means 10 centimeter water, right? So when we inspire and then expire, air comes out of the pleural cavity and it battles the pressure in the collecting chamber. So if it's leakage, that will bubble. Yes. So as we've seen, those are the two procedures. We have thoracentesis and you have chest tube. And I would be proud to say that probably you have a good grasp of lungs anatomy and some aspect of uh, both physiology and pathophysiologic lungs. So diaphragm, just bear with me, probably a few more slides before we end our topic for today, and you enjoy your weekend. So the diaphragm is a musculotendinous structure which separates the thoracic cavity and the abdominal cavity. So it is innervated by 3, 4, 5, C3, C4, C5. And Okay, sorry about that. So its main function is inspiration. So when it contracts, you would imagine that the dome of the diaphragm, here, one, the dome actually contracts and it forms, this is the relaxed diaphragm. When it contracts, it forms a dome, here. And when it contracts, what it does is decrease, the pleural space. When you have an elevated diaphragm, you decrease the space in the thoracic cavity. So the components of these would be your musculotendinous unit. You'll be able to, you should be able to see openings. Openings mean what would be the organs passing by these openings. So here you have the inferior vena cava. You have the crux of the diaphragm, the right and the left crux where the esophagus pass, and the aorta. Crux meaning where does both the right diaphragm and the left diaphragm pass. So it's called the crux. Crux, it's a termination point. So you see here that the crux or the cruise would insert at the L2 and at the L3 of the lumbar vertebra. So you have the aorta, the esophagus, and the IVC. And blood supply here would be the different musculophrenic arteries. So the phrenic artery, as you've seen, comes from the aorta. So again, the domes or the cupula, you have the base of the diaphragm, the muscular part, the tendinous part are in the middle, like your tendons. We have seen hamstrings, biceps, you have your triceps. They both have muscular and tendinous parts. And they probably forgot to highlight the insertions, the crux, as I told you. The attachments would include the siphon process anteriorly, T8 to T9, anterior. You have your costal margins of the thoracic wall. You have the inferior margin would include the ends of the rib 11 and 12 here, 1 and 2. That would probably be rib 11 and rib 12. And the insertion would be, as again mentioned, the crux of the left would be at the L2 and L3 for the right crux, the vertebra of the lumbar region. Structures which pass through, favorite exam question, you have your T8, your inferior vena cava, and your right phrenic nerve. T10 would be the esophagus. You also have your great splanchnic nerve, and as I was saying, your lesser splanchnic nerve. You have your thoracic duct with your aorta, with the left crux and the right crux of the diaphragm. Blood supply would include lower 5 intercostal and subcostal arteries. Muscle fibers would arise from the crux. The other contributions would be internal thoracic artery, which form the pericardiophenic and musculophrenic as end arteries, and the thoracic aorta, which gives you the superior phrenic artery. Third supply, as I said, 3, 4, 5. If you break your neck, you lose your diaphragm, right? I don't know if you've heard or probably have always come across the example of Christopher Reeve, our Superman. Equestrian fell from the horse, broke his C3, C4, C5, diaphragmatic paralysis from a spinal cord injury. I hope you know him. He was the original Superman. Sensory proprioceptive would be the costal margin by the intercostal and the phrenic nerve for the central area. So as I said, contraction of the diaphragm gives you the dome. So the effects that it does is decreases the intrapleural pressure. It inflates the rib cage, and expands the rib cage by generating positive intra-abdominal pressure. Abdominal pressure. So when you increase the positive abdominal pressure, you expand the rib cage, increase the volume as well. So the different cavity, so from the abdomen naman ito, this is different from inspiration and expiration. This is probably the contribution of the diaphragm. What it does, increase the intra-abdominal push, so that you'd be able to expire. Pathophysiologically, CDH, no? Congenital diaphragmatic hernia. Patient newborn or probably newly discharged from a local hospital or a lying-in clinic, no? Where there probably has no prenatal checkup. One probably has failure to thrive, shortness of breath, or probably in our young or in our newborn, takipnik, no? May halak. Yan po ang sasabihin, inuubo. So when a chest X-ray is done, you see suspicious opacity, suspicious loops. So probably when you do a CT scan, you will be able to see bowel loops, no? Because in congenital diaphragmatic hernia, there is a defect on which sometimes the stomach here herniates into the chest cavity. And it herniates because, aside from the fact that there's a defect, because there is negative pressure in the chest. So what happens? The abdominal contents are technically sucked into the chest cavity. Most common is the Bok-Bellet hernia because this is a posterolateral protrusion. Posterolateral defect in the diaphragm. Mergagni hernia is more on the anterior, and the diagnosis is by GI study or just a CT scan. Other cases are asymptomatic. Other cases are obstructed. Obstructed meaning because the bowel loops or because the stomach is in the chest, there's a portion wherein there is a tightening, because if the stomach herniates into the chest, the defect is small, so the stomach won't be able to pass through and might be able to pass through, but there's a tightening. So patient may present with vomiting, and this can be relieved by decompression. You have your NGT insertion. So the definitive also obviously reduction of the bowel contents down to the abdomen and repair of the defect. So here you have a suspicious, suspicious, I would not say loops, but suspicious lesion on the anterior aspect, and probably on CT scan and on further examination, you would say that there is organ into the chest wall. So here, I think they did the barium swallow, so they saw the swallow or the radio opaque material, probably representing the bowel loops, should be here. So lo and behold, why is it in the chest? Why is it near the diaphragm? Why is it near the heart? So this is probably a positive sign as far as your barium study is concerned. Diaphragmatic paralysis, as I said, could be from trauma or could be from infectious processes, POTS disease, tuberculosis, malignancy. You have your vertebral lesions. So when it happens, you should have problems with your inspiration and expiration, and you would be able to exhibit paradoxical motion. And for this, what we do is diaphragmatic pacemaker. No? We introduce electricity or electrodes so that you will have synchrony of your contraction. So eventration is different from CDH. Eventration is fibroelastic tissue representing the muscle. There is a separation between the abdomen and the thorax. Thorax and the abdomen. There is a separation. There is a tissue, but it's not a muscle. So when you inspire or when you go through your cycle of respiration, there is no contraction happening because it's not a muscle. So it's called eventration. This is actually a misdiagnosis. Usually when you see bowel loops into the chest, oh, it's CDH, it's diaphragmatic hernia, but lo and behold, CT scan actually shows there's no defect, but there's just a fibroelastic tissue replacing the diaphragm. So this is actually diagnosed by fluoroscopy. When you inhale, you see that the contents go up and down. Traumatic hernia occurs in blunt chest or blunt abdominal injury. Obviously, you have a closed space, you have the pleura, you have the abdomen. In high impact force, like for example, blunt chest trauma, you have your seatbelt on, moving at high speed, and then when you encounter blunt chest or blunt abdominal trauma, pressure increases intra-abdominally, so it will push your abdominal contents up the chest. So what happens is it might be diaphragmatic rupture somewhere along the insertions, or as we have encountered on the dome or on the tendinous part. The muscles are fairly thick. So on the tendinous part, there could be a rupture. And some of these patients end up not being diagnosed at first. They have trauma 5-10 years ago. And then they present to the emergency room obstructed. No? And you see, why is there bowel loops on the chest? And you want to investigate. You want to ask them, what happened to you 5 years ago, 2 years ago? Did you have trauma? And they would suddenly remember, oh, I figured in an accident. Oh, I fell from the stairs. Oh, I had a stabbing injury. No? Because sometimes if you do your physical exam, there is a stabbing injury. No? Nasaksak pala siya 2 years ago. And you will ask them, what happened? No? So I was stabbed 2 years ago. Anong ginawa? Wala po. Just a chest tube. And they were able to evacuate the blood. That's it. But unfortunately, there was an occult, there was a mist, or there was a hidden injury. Aside from the lungs being punctured, the diaphragm was punctured. So there was a defect on the diaphragm. And it presented like after years. And so contents of the abdomen probably through negative pressure sucked into the thoracic wall. So what looks like is a bowel loop into the thoracic cavity. Neoplasms would be in the form of fibroma, neurofibroma, neurylomoma. These are very rare. So that gives or concludes our lecture on surgical anatomy of the lungs and diaphragm. I hope you understand. I hope you also are able to go through our asynchronous activities. I hope to give you PowerPoint slides as well and copy of this lecture. And for today, if you don't have any questions, thank you very much for participating.